Alrighty, so let's jump into the next section. What I thought I'd do is take something very practical that we were all exposed to this morning during breakfast, which is the sterno equivalent. So how do you create fire with this? What's it take? Fuel. What's the fuel? The stuff, the flammable stuff that's in the container. Where is the oxygen? In the air, 21%, right? And then how do I start this bad boy? I need a spark, I need a match, I need a something, right? I mean, that literally is how practical this is to kind of begin to think about in the event review. And I'm just going to give you a little historical background as we jump in to do this, and we'll do a little bit of just culture, and then you're going to have a chance to interview the neurosurgeon. We had almost zero fires in the operating room up until the 2000s. Cyclopropane was the last flammable anesthetic that we used, and it got banned in the 50s and 60s because of all the fires used to happen all the time. That was the fuel. And obviously you had plenty of oxygen around, and you had cautery and the rest of it. So why did we then have this huge epidemic and rash of fires? It was the use of what? We had always had cautery. What started being used in the 2000s and why?
The certain kinds of prep.
The prep. Why were we using the prep? The Durprep, Chlorprep. No, why were we using it instead of the old chlorhexidine? What's the difference between Chlorprep and chlorhexidine? What's the difference?
They said over here, I heard somebody say. What did you say?
What's the difference?
Infection prevention. Yes.
Infection prevention, and alcohol-based prep solutions were known to prevent infections. So we went from chlorhexidine, which had no alcohol in it, to Chloroprep and Duraprep, which has a lot of alcohol in it, and that's when we started to see a bunch of fires. It was being used as the push to reduce surgical site infections. And that's what changed in the 2000s. So we'll talk a little bit about that. We're going to hopefully be able to do a nice deep dive here. The other thing I wanted to mention, Bruce and I talked about this, and it is so scary to do this part, but there is this tendency in us to kind of try to manage these conversations. And the analogy I like to use is it's not like rowing a canoe down a river. It is like being in a kayak, and you got a lot of rapids. And so you just got to go where the river and the rapids take you. And the more you try to control it, the more you run the risk of capsizing. So when these things go this way, sometimes you have to just go with it and stick with it and stay with it and use a lot of the techniques and other stuff that Bruce mentioned related to that. So now we're doing the event review. So as many of you may know, there's going to be a whole lot of stuff that you're going to want to try to get out of this. The first thing you're going to do is interview the neurosurgeon. It's going to provide you a ton of information. The next thing you're going to do is interview me, because I have a lot of the context issues that I'll be able to share with you. There's a lot of other stuff that went with this case. We talked about that immediate response and why it's so important at the beginning, right? So leadership needs to know there's a fire. You've got to take care of the patient right away and the family. Think about care for the caregiver here. Oh my gosh, all those people who saw it. I tell you, it is terrifying when you open an OR up and smoke starts billowing out. As we talked about, you got to get that time-sensitive information, and then you got to identify, just like somebody over here mentioned, you need to find a content expert as it relates to these fires. And there are different people who should be able to do that. Most anesthesiologists should be able to speak to fire in the OR, because even before cyclopropane was banned, it was something we were all trained about, because we use oxygen a lot of times, we use laser, we use other things that are related to it. But you gotta think about doing that interview, and then we're going to get into let's see if we, when we're done here, totally understand what's going on, because then we want to develop solutions, right, to what are we going to do to fix this, because we need to know that before we go in and we have that follow-up conversation with the family and start to prepare for this. So just culture, again, just a very quick review. As you know, human behavior tends to fall into the three buckets. One is the reckless behavior, the other is at-risk behavior, and then finally there's the human error going along with this. As you listen to the cognitive interview, as you listen to this other stuff, think about how you're going to apply some of the just culture principles, because as you know, culture eats strategy for breakfast. To have Candor really succeed, you really need to have the culture issue developed. So when it's normal error, you need to support people. You need to have system redesign. At-risk behavior, you need to coach people. And finally, with reckless behavior, sometimes you need to sanction or discipline folks. But very, very rare. Even though your tendency, imagine from the family's perspective of being very confused and obviously very upset about the fact there was a fire, there's going to be at some point through their mind, think about it later this afternoon, oh my gosh, somebody better get punished, for doing this. And how are you going to manage that? So as we begin to think about this event, we've used these quotes before. The single greatest impediment to preventing is that we punish people for making these mistakes. And fallibility is part of the human condition. We cannot change the human condition, but we can change the conditions under which people work. Think about that in the context as you're learning more and more about this fire and how it happened. So now we're going to do the cognitive interview. Okay? And remember the strategy for doing that, because we're going to have you for about 5 minutes at your table. Think about, if you're the person interviewing the neurosurgeon, what kind of areas of inquiry do you want to go into? What kind of open questions versus closed questions? And we talked about that, at the last workshop. What kind of open questions are we going to ask? This is where you need a lot of a silence. You need some emotion to be there, because this is pretty terrifying. And try not to interrupt when you're trying to get a sense of what it is that happened. And remember, the whole goal here is to avoid jumping to conclusions about what happened. Try to, as much as you can, avoid hindsight bias. As we have said before, for the people in the operating room, which will have included who all will be in the operating room, that at some point you may want to interview. We're going to start with a neurosurgeon, but who else will have been in the operating room that you may even be able to ask the neurosurgeon about? So you may have an assistant surgeon. Who else might you have?
Anesthesia.
You have the anesthesiologist and maybe their person. Who else will be in the OR? The surgical tech, the one who's scrubbed in. And think about that on the care for the caregiver side, because they're right there when this bad baby thing, horrible thing happened. Carol.
What about a device rep?
Well, so there might be a device rep in there at the time. In this case, that turns out not to be true, but sometimes you do need to think about that. We did have a horrible burn related to the misapplication of a Bovie pad in one of our cardiac rooms. And the greatest amount of liability actually stood with the device rep, who was misinforming people about how to use it. You're also going to have the circulating nurse, right? So circulating nurse, scrub tech, surgeon, and others. For whatever reason, none of those people came in to start a fire. Everything made sense to them at the time what they were doing until the smoke came out. And so you need to get into the tunnel. You need to find out what were they doing and why did it make sense to them to do what it was they were doing as you piece this together. So you want to introduce yourself, what your role is. You want to set expectations early with the neurosurgeon, is what is the point of this conversation. You want to open-ended questions so you can get that narrative and just keep going. Keep having them reflect back and think about what it is they remember and what happened. And then guide them into the information-rich areas when you're hearing things and you're going to be thinking about taking notes. Oh, I need to go in there and maybe ask some more questions. And then you want to review what it is and then, let them know that you're going to reach out to them again maybe, because you got to talk to a bunch of people. If they think of something else, here's a number to call, here's how to do this. The goal is to learn what happened so it can be prevented, right, in terms of doing that. So, again, don't interrupt. I would probably say don't interrupt, and I would probably suggest very strongly you don't want to interrupt. When you're doing this, the tendency is just to continue to do that. So this is one where it's very important. And then think about, just like shot across the bow, think about that open-ended question or questions that you may use to start getting the description of what it is. And remember, the greater the rapport is, the more likely people are willing to share it with you. So as you know, we recommend when you do cognitive interviewing, the boss is not interviewing the person that reports to them. That was a big takeaway, I know, at Workshop 2 that people felt was really, really important. When you set this process up and you identify the people doing interviews, you, to the extent possible, really want to avoid it being their boss, because, again, it's just that natural tendency to want to not necessarily bare your whole soul about what it is you know that's happened. So take 5-10 minutes at your table, think about, practice some of the questions that you would like to ask, the information you'd like to get related to the triangle, right? Oxygen, spark, fuel, all that sort of stuff. And then when you're done, we'll find a volunteer from maybe Jerry's table, because they're really smart and really good, and who will come up and just have a conversation. This is a little less stressful. It's not quite like you don't need a shot across the bow, because they've already been shot at, right, by this. So it's a little more comfortable, you know, sort of doing that piece. So take 5 to 10 minutes. Bruce and I will walk around. You also have, that may be helpful, you know, you have that document there where you can really flip through that was given to you, so that it'll kind of prompt you a little bit about the kind of things that may be worth asking, you know, related to this. So, and then we'll do the cognitive interview, and then we'll pull this, try to pull the whole scenario together. So the one other thing I mentioned to you is, as you know, those at other workshops, but here I think it's really clear to know, you're only going to have one person go in. Sometimes there'll be 2 people when you do an interview here. The expectation is there'll be one person, just like when you do peer support and care for the caregiver, it's usually one-on-one. So when you're thinking about this, think about who might be the ideal person to go in there and do it. Sometimes you might bring a scribe, but in this case we won't do that. It'll just be, you know, one person going up there. But thanks, Bruce, for clarifying that. right, I'm going to have Dr. Paul Phillips come up to the stage and grab a seat. And Bruce, have we found a volunteer?
We have not found a volunteer yet. Do we have a volunteer who would like to come up and do this interview? In this case, it's only one individual person. One person. I heard some people who sounded quite prepared. Who would like to volunteer and get the most out of this learning today?
And it can't be David or Dar.
That's right.
Let's just put it that way.
David and Dar are the only ones who can relax.
Well, they can't relax because they may get called on the spot later. But
Who would like to volunteer and do this interview? Much easier this is than doing the disclosure. No angry patients, only an angry surgeon. No, I'm just kidding. Who would like to do this volunteering? We need someone to help us learn.
I'll go for it.
All right. So just his background again, this is Dr. Paul Phillips. You are not his boss.
Could you?
You are part of the event review team, and how that would fit into that, kind of piece and the rest of it. So he probably knows you, not particularly really well, but it's not like, hey, he's never met you before or what have you. So you already have a little bit of knowledge of each other in doing that. So we'll just have you go up there
Tell
and
us who you are in real life.
yes.
My name is Clay Dahlquist.
Yes.
Okay. I'm the hospitalist at Waverly Health Center, but I also function as a part-time chief medical officer.
Awesome.
And the role you'll be playing here, what role do you think you'll be playing?
Probably
Did you say the
CMO, I would think from our discussions or my personal thought on this.
Perfect.
Right.
So,
At least how our CMO functions at our facility.
excellent.
Yeah. And he's an independent physician, so definitely isn't. You're not his boss. You're overrun the whole hospital as well, but you're not in his department or over that piece.
Okay.
Good.
Paul? Yeah. Hi. Remember me from med staff? My name's Clay.
I do, yeah.
Yeah.
How you doing?
So how are you doing, sir?
Okay.
Okay. Well, I've been asked to come here just to talk with you to get your perspective on the incidents that occurred. I'm assuming it was today yet in the OR. So I just kind of wanted to open the floor to you to kind of just tell me what happened and how things went down.
I was, the gentleman needed a burr hole placed, and it kind of feels like next thing I know that there's just smoke and fire just all in the OR, and I'm just, it just feels like a bit of a blur, to be honest with you. It's quite frightening, I think, for everyone that was there. Obviously for him more than anyone, but God, I don't know.
How have you been able to take a little time off or get your breath here yet? Or are you still under a lot of pressure?
Yeah, I mean, you know what it's like here. It's like a revolving door of patience. But no, I mean, it's definitely been playing through my mind. Yeah, definitely had time to think about it. Yeah.
Have we been able to reschedule your cases and get you the things that you need to take a moment?
Well, I'm sure we'll get that sorted out. I'm not too concerned about that aspect of things.
Okay. So, do you care if I take notes here? I just
No,
want to have a
please,
better
yeah.
understanding of what's going on or what we need to do to move forward with this patient incident.
I understand. Yeah.
Okay.
Please.
So again, what do you feel caused the fire?
Well, I know the electrocautery had something to do with it. Yeah, I'm sure that was at the root of it, to be honest with you.
Okay. Was anyone else injured besides the patient in your mind, or have you been
No,
able to follow up with your team?
I believe it was just Mr. Stevens, I think, unfortunately. Yeah.
How is Mr. Stevens right now then?
He's, as far as I'm aware, I don't know, all of the details. I think he's doing okay. But, we're going to have to see him again, soon.
Yeah. Are you still involved with his care plan?
I think I will be, yeah.
Are you comfortable with that?
Yeah, I think I am. I think I owe that gentleman some a home one for sure.
Yeah. Have you been able to communicate with family members or anyone about this so far, or what is your feelings on that?
I'm not. No. I've not had contact with him yet.
Yeah. It sounds like you're still, in shock from this, and I fully understand that. I just wanted to know how administration and myself can best help you through this situation now. Do you have any thoughts on that?
I think I'm the least of your concerns right now. I think Mr. Stevens is who we should be focusing on, and what happened to him. I think that's what is most important here.
Okay. Well, we value you as a surgeon, and we want to make sure that we're there for you and for the patient.
Yeah. No. I appreciate you saying that. I really do.
Okay. Thank you. Let me just see here. I was thinking about what do we all need to discuss today, and primarily the vents in your perspective are the things that I'm interested in, but I don't think right now is appropriate time. I think it's just too emotional right now. So I would ask that you take some time to possibly write down the events as you recall them. And the things that I would be interested in would be, processes and the things that you usually go through, and where was everything normal?
I mean,
I think we're going to have to do some type of an analysis of this, and I just want you to be prepared for that.
Sure, and like it is, it is shocking. You're right, but I can remember it clearly. We can go into it if you want to. I don't have any problem with it.
Yeah, right. I'm not sure that right now is the time. Like I said, I want to make sure that you're taken care of right now, and I think we can look into that. I think our primary goal as a hospital is to make sure that the patient's being well taken care of.
Okay.
Okay. So is there anything that I can do for you right now?
No. I mean, if that's what you want to talk about, then that's fine. I mean.
All right. Well, I do want to let you know that some of our other administrative team members may want to interview you or talk with you down the road here.
Sure.
And that's kind of why I wanted you to have some time to write your notes so that you can have your thoughts.
Yeah, I mean, it's pretty clear, to be honest with you. I think as I said, it's doesn't take too much.
Why don't we stop it right there? So let's give Clay a round of applause, and also Andy. Okay, so that unfolded a little bit differently than I imagined. So I wanted to hear your thoughts. So. So we approached this as a cognitive interview. It seems like you took a slightly different tack on this. So what was your approach to this surgeon?
At this point, mentally, I didn't have a good idea of where we were in this process. And his responses and body language to me was that he wasn't in a position to talk or discuss it. I gave him several opportunities to tell me about his perception of the events, but he didn't really want to articulate that at this time. So I backed off of trying to find out a description of the events there, but I wanted to try and inform him that we needed to get there and that it may be me or someone else doing that. So I decided my goal at this point was to let him know that we're his advocate as a facility, and that we want to get through this together, so that he doesn't feel that he's being accused of any wrongdoing, because I personally feel as a physician, whenever these things come up, that your assumption is that everybody that's showing up wants an answer.
Yeah.
And would be more in place that we automatically place ourselves into a defensive mode. Whereas the only way for me as a CMO to advocate for him is to have his trust, to open communication, and let him know that I'm there to help him through this.
So you approach this as almost as like a care for the caregiver interaction rather than as a cognitive interview. Could you talk about that?
That, like I said, I didn't get anywhere with the questioning, and that I wasn't getting where I wanted to go, so I didn't want to push.
What did you expect that you didn't get? Like, what would have been a clear signal that he was?
Just a discussion of the events, what happened to it, what their concerns were about the care plan of the process, and I don't normally do a cognitive interview, so my perception of what needs to be obtained is different than someone else's.
I
guess,
think
at this
that you're
point.
on the right track about what needed to be obtained. So were you put off by the fact that he was still a little bit visibly troubled by this?
I wasn't put off. I was accepting
I see.
that, or I hope I portrayed that I was accepting of
You
that.
did, but were you put off of the interview part? Did you feel like the wound was too fresh to pursue a sort of detailed line of questioning about what
yes,
happened?
yeah.
What were you afraid was going to happen had you pursued that more?
That I was going to assign guilt or blame to the provider, which would then close my communication in the future.
I see.
My communication option in the
I see.
future.
So one of the concerns we have in terms of an event investigation and a cognitive interview is to try to get this information while it's still fresh. We don't want too much time to elapse. So what's your point of view about how much time might elapse between, if you're gonna say now go take care of yourself and we'll do this interview later, when would later be?
Later, I didn't put a good definition on it. I was going to say later was later that day, depending on the time of the day, or tomorrow.
I see.
That's why I asked him to take a moment to kind of get his thoughts down on paper or something so that it was fresh in his mind.
I see.
And my intent was
Tim,
to circle
did you want to
back
follow up,
quickly.
and then I'll ask Andy what is it?
Yeah, well, no, I mean, you got that feeling. You did the right thing. I think this was a really interesting way that it went, responding to how the person is. There is a sense of urgency about learning what it is that happened and why. What are the various senses of urgency where you're not going to want to wait too long to find somebody who you believe will be able to just ask him the open-ended question. Can we just start from what happened the minute you went in the OR till you're done? Are you comfortable talking about that? Because that's really the only question you need to ask. But why is it so important to begin to learn that in the first couple of few hours of the event?
So that, I guess, so that our biases don't start to change.
There's a little bit of that. What's
perception.
other really critical reasons that in a case like this, you're going to want to get that information as quick as possible? What's that?
Recall diminishes that.
Recall diminishes. What else?
And the things that are in the OR that
Things in the OR, you're going to need what else? I'm seeing Carol right here.
Don't you want to you want to be able to give answers to the family?
Exactly. Remember, you told the family, you saw the first discussion. Dar said, I'll be back to you within the hour. So there's going to be this sense of when you go back, you're not going to want to say, well, it's going to be tomorrow, that we'll be able to come back. So there is this sense of, who do I need to have to come in? And maybe the CMO isn't the right person. There's one other really big reason I'll just say, and then we can jump into it, Bruce, because we should, bring somebody else to do the interview.
Yeah.
Your next patient may be ready to catch on fire in that operating room. This was super unusual. You're going to want to have as quick a because there may be something really unusual going in there, and you don't want the next person catching on fire. So when you have one of these critical events, to the extent possible, you want to do everything he did. Create rapport, do that. If you feel like it's just too fresh or what have you, do what you did, which is, I agree, but boy, you're going to want to get somebody in there pretty quickly to be able to do that. To talk to the family and also make sure you can step in and prevent it.
Yeah, we never want to criticize anyone for being too empathic,
That's right.
And so you were right there doing a great care for the caregiver thing, but the goals of this interview were to get in some way there's a division of labor where some people's job it is to be empathic, there's a care for the caregiver team, some people's job it is to get the information. And it seemed like you were straddling those two different roles. So let's give Clay a round of applause. We're going to give someone else a chance to give it a try.
No, and that was wonderfully empathic, Bruce, and I could see there are many times in real life that happens that way, where you go, whoa, okay.
Yeah, you're not ready for this interview.
Yeah, from me, because there may be this truth to power piece here, with the CMO being there, even though it's not his boss.
I didn't give Andy a chance to say anything. I think he wanted to say something.
That's right.
Well, no, it was just because it was an interesting, the interview went in an interesting direction, and I think overall, Clay, you're very empathic, affable, your body language is very sensitive to mine. Maybe my recollection is wrong, but as far as I can remember, you only asked me once what happened, and I did give you a short answer the first time. But then, maybe I was sort of giving off a body language, but you didn't actually ask another open-ended question of like, can we go back and sort of, just and actually a couple of times near the end, I was like, I'm kind of clear.
I'll talk. But I think that the words and the music, like what you were saying and your body language were not met, and I think Clay was just tuned into
the body
how
language.
you looked.
Yeah.
And you just looked distressed, and I think he made a conclusion, you're too distressed to do this now.
Yeah.
I'm not totally positive that was the right conclusion, but it was certainly a reasonable one to make under the circumstances. Tim, we have time to do another interview. Let's give it
we
a
got
try.
tons of time.
So
we're not going to do the enactment of care. We saw care for the caregiver here
there
a
was
little
a little
bit.
care for the caregiver
No, it was beautiful.
Yeah.
And then we'll see it even more after lunch. But here we're ready. We've got more to learn about this event.
Yeah, what we'd like to do now is get another volunteer to come up and grill Andy harder. Oh, we have a volunteer,
All right.
Michelle, right away.
Here you go. Here you go.
Let's give Michelle a big round of applause. That was kind of half-hearted.
All right.
Now, remind me again what the neurosurgeon's name is?
Paul. So, Michelle, could you tell us who you are in real life?
Okay. My name is Michelle Kelly. I'm the executive team lead for safety, quality, risk management, et cetera, at a very, very small hospital in Storm Lake, Iowa.
Are you a physician or are you a nurse?
I am
Or
a
you
nurse.
You're a nurse. Okay.
I am a nurse.
Okay, and
Yeah.
the physician's name is Paul. Your name is Michelle. And what role are you going to play in this?
Okay, what I'm going to do is I'm going to build on what Clay just did.
Okay.
So Clay did a nice job providing support and empathy.
Yeah.
And now he's sending in the interviewer.
Okay.
Okay, so
It's a good cop, bad cop.
Yeah.
In comes the bad cop.
So I'm going to be the
Absolutely.
interviewer. So I want to be sensitive to what Clay just did.
Are you the CNO? I'm trying to think organizationally. Who are you?
So organizationally, I'm going to be the risk manager.
A risk manager.
Okay.
Okay. So whenever you're ready, Michelle.
Yeah. So Paul again, right?
Yeah,
Paul.
Paul,
Okay,
yeah.
Paul. Hi, Dr. Paul. I'm Michelle Kelly. I think you're acquainted with me.
Yeah, I recognize you.
Right. I'm the risk manager here at the hospital, and I know Clay was meeting with you just a very short while ago.
Yeah.
He kind of, briefed me on where you're at, kind of in your emotions with the event that happened today. In my role, I would really like to kind of get more information about how everything flowed today so that we can learn as much as possible about the event with a couple goals here. Number one, supporting you. I know that this is,
Thank you.
well, I sense that perhaps this is really a difficult day for you, right?
Well, yeah.
For the organization, for our patients, for the individual involved, we want to gather as much information so we can assure future safety and improvement and just really dig deep into what happened. Are you feeling able to talk about this right now?
Yeah, I think so, yeah.
Okay. Has your slate been clean for the day? Are you free to talk for a little bit?
Yeah, I'm fine for just now. I'm not sure what the rest of the day will entail, but...
Okay. Let's start from the beginning, should we? Let's talk about what happened from the time you entered the room until the time you exited the room in the best that you can remember.
Sure. Well, let me see. I came down to the OR. The room was very quiet. The patient was quiet, obviously, and everything was sort of prepped. There was towels on his face, and obviously the surgical site was open. It had already been shaved, and it was he was basically ready to go, and I I went about cleaning the site. I used the DuraPrep, and
Okay.
I didn't.
Did you follow what you would normally do? Was this like every other time you've done a case similar to this, or was there anything different
No,
about
it was.
today?
The hospital was chaotic, but it's always chaotic, so I can't really sort of lay any blame there. But felt kind of, run of the mill. As I said, I sort of cleaned them up, and then next time I left the room was immediately after that to get washed up and prepared while the solution dried. And I now know how much alcohol was in that stuff, but truth be told, I wasn't aware previously.
Were the materials for the preparation available and ready to you, or did you select the items, or were they
Everything
already
was,
there
No,
for
everything
you?
was ready. It was very professionally done. It was all
And
good.
it would have been what you expected to find for preparation materials, or was anything different regarding that?
No, there was nothing different. It was everything that I expected. Yeah.
So you, just to kind of recap what you just said, you came in, patient was draped, and you were then prepping the skin area, so you did the cleansing yourself,
I did.
okay? And then did you leave the room at that time, did you say?
I did, yeah, just to get washed up. And
Okay.
Get up, yeah.
And was it a matter of minutes then, and you returned, or?
Yeah, minutes, yeah.
Okay, and when you
Absolutely.
returned then, what was the situation with the patient at that time? How did you find things?
Patient was, as far as I was concerned, was ready to go, so I give him some epinephrine and some lidocaine
Okay.
through a syringe. And then we had a timeout. Then we had a sort of like,
Right,
this is Mr. So-and-so, this is what we're going to be doing today.
okay.
We chatted through it a little bit with everyone in the room.
Was everyone involved in the timeout?
Yeah.
What kinds of things did you cover in the timeout?
Not fire.
Okay. And would that be how it would normally occur? Is that?
Yeah, no, we just
Okay.
we just all with regular stuff.
Right.
But
Does anyone, throughout the timeout, is anybody checking items off of a list, or is it, tell me how that happens.
I'm usually the person sort of going through the list, but I'm not the person sort of making notes or ticking any boxes. I'm not sure if that was done or not, but
Okay.
it's all up here usually, just running through it, and it seemed like it was again like any other procedure, and so I did not expect what did happen to happen.
Okay. So you did the timeout, and then what happened? What was the next step? What happened next?
So we were ready to go, and I said we're all ready. So I made an incision, and predictably started bleeding, and so I grabbed the electrocautery and then applied it, and the patient started moving, and I think, what the f- is going on here? I shoot the anesthesiologist daggers. I'm like, what is happening? And they tell me, well, I've sedated him through an IV, and I start to think, okay, this is, I had assumed he was under general anesthetic, and how I know there's oxygen, and I'm just like, well, you better give him more, and I just need to get this done now. And man, he just sits up, and then just smoke everywhere in flames, and we were like, oh, like it was.
I can only imagine. What were you feeling at that moment?
Panic, I think, more than anything.
Indeed. I want to reflect back on something you just mentioned about the anesthesia. Is the type of anesthesia that the patient was to receive, was that something you and the anesthetist had discussed in advance?
No, it wasn't. I made an assumption, and I thought someone would have told me that they weren't under general anesthetic, but
Okay. What would your normal process be for discussion around anesthesia?
now that I'm just thinking back, and just I should have. I didn't hear the ventilator going, and I should have. I would have known if I'd tuned into that. I think I would have. I would have clocked it earlier.
Okay. And through this process, our goal really here is to gather the information and in no way render any sort of judgment or criticism. So I want you to be able to feel really safe in telling us every step so that we can learn from that. I'm sure at this point you might be feeling lots of emotions. What sticks out? Where are you at emotionally with that?
It's hard. Yeah, you're right. There's a mixture of emotions. It was visually, it was just very shocking. You know what I mean? Just when you sat up and there's like smoke and flames, that's just something that's just the furthest from your mind of what you expect in that moment. And so that's sort of replaying itself, you know, kind of concerningly in my head. And that is it's difficult, but you know, I'm okay. But it's quite frightening.
So let's then kind of start back in again and just kind of walking through, picking up where we were. So at this point, the patient has moved, and you are alarmed, shocked, scared.
Sure.
What happens next?
Bit of a mad dash, actually. Just, you know, getting wet towels on him, you know, just trying to do what we can in that immediate moment, and it was dealt with pretty quickly. And yeah.
Okay. From what that you've had just a very short period of time to think about this. These events are very, very fresh. Emotions are very raw. Do you have any thoughts around what was different about today that you experienced as opposed to every time when things go as planned? Is there anything you can reflect upon and say, this was different, or normally this happens and didn't? Or, you know, we talked about the anesthesia. Was there anything different around that today? You mentioned you normally would hear a ventilator.
Yeah.
Is there anything more around that?
That's just one of the sounds. That's just like a background noise. It's not something that I'll mentally
Pay
check off a
attention
list.
to.
It's just
Right.
that
Right.
now I can
Right.
recall that. But
Right.
just bad luck. No, not bad luck. I can't. It's not luck. It's irresponsible on my part in many ways. But I just think that it's a bit in the heat of the moment. Just the communication lines were blurred. Were bad. As I said, it was busy, but that's not really an excuse.
What about others in the room? Is there anything that occurred, conversations you heard, or things you would have expected to have happened that others may have been doing that didn't happen today?
Truthfully, I would have expected someone to. I would have expected him to be under general anesthetic.
Okay.
And I was surprised that no one for that procedure told me that he wasn't.
So a briefing of a key piece of information that could have helped you deliver safer care was missing for you?
Yeah, but I mean, if I'd known, I would have done the whole thing, the procedure differently. But I can't. I don't want to throw anyone under the bus here. But it's my responsibility.
Right. And I very much respect that. I don't want to throw anyone under the bus. That I respect your feeling that way. And what I want to assure you of is, from an administrative standpoint, we really want to approach this from a learning opportunity and without blame, without shame. So we really need to dig very deep. So if there are other pieces of information, recollections you have, no matter how you might feel about, well, that would shed a bad light on someone else, we really need to be able to get at all pieces of information.
Yeah. No, I appreciate that. Let me just think. I think. No, I think that's about it.
Okay. Well, one of the things we really want to do is be able to go back to the family with updated information. And so we have talked with them just briefly. So our plan is to go back frequently with information as we gather. And so anything that you might recall moving forward, this won't be the first discussion we'll have. And as I mentioned, we're going to be talking to everyone who was in the room in the effort of learning, improving, making sure we're safe, and informing the family and working with them.
Yeah.
But we also want to make sure you get what you need.
I didn't know there was so much alcohol in those things, honestly. That really surprised me.
Let's talk about that a little bit. So you mentioned that all the items for the prep were on the table, and it was what you would have normally expected to see?
Yeah, I mean, I used a lot of that stuff, you know what I mean? Just because I wanted that.
And tell me about that. Use a lot. What in
Well, I
your...
was like 2 26 mil applicators with the Dura prep, and I went through them both, and
No.
and now knowing what I mean, that seems crazy.
So I just want to make sure I understood you correctly. There were 2 applicators that you used for the preparation. Okay.
Yeah. But like I said,
Right.
I wasn't aware that it was the alcohol content in them was so high.
And these were the large applicators?
Yeah,
Larger
26 mil.
size.
Yeah.
Okay. Yeah, we're looking deeply, of course, into this, and it to maybe share with you that seems the general practice for our surgeons is to use the larger size. So in that, you're not unusual. That will be an area that we'll really need to kind of take a look at and develop some process and best practice around.
Yeah.
I think we're going to learn a lot from this.
Yeah.
Your input is critical.
Thank you.
This is tough stuff, and thank you for being as open as you have been.
No, I appreciate you you chatting to me.
So stay in character. No, seriously, both of you. Anybody else in the audience have any questions they would like to ask? You guys stay in character. Any other questions? Go ahead. Hang on, you need a chat box.
I would like to know if he has annual training on fires in the OR or on the proper use of the prep.
Okay.
No. Pretty simple answer. No.
Yes, so exploring what he already has been taught, and yeah, that's a key area I didn't even touch on.
Okay, stay in character.
So,
any other questions? Oh, sorry. I got one over here.
Yeah. So regarding the prep, is it customary for you to use 2 large syringes normally in a procedure like this, based on your experience?
I didn't use 2 syringes. I used 2 of the cleansing applicators. Yeah. But yeah, it would have been customary to use what I use. I like to be thorough and yeah.
Do you typically do your own prep?
Yeah.
This works.
I think I heard you mention minutes between using the prep and making the incision. Do you know, or did you time, or do you know if anyone else in the OR was timing the dry time?
I don't know if they were timing the dry time, but it was, I mean, I was going to wash up, get my gown on, we had the time out. I mean, it was, I'd like to think it was enough time for it to dry.
Do you know if there is an established dry time?
I don't know. I don't know.
So you mentioned that if you had known that the patient was not under general anesthesia, you would have done things differently. What would you have done differently?
That is entirely beyond my pay grade to know.
Stay in character.
Vincent, question over here.
Who was in the room with you that day? What was your team member? Who were your team members that day?
I think there was about 4 people in the room. Is myself, the anesthesiologist, the scrub tech, and the circulating nurse. That was it, I believe.
Dark?
And what were those individuals performing? What tasks were they performing?
Nothing out of the ordinary, just their jobs, you know.
I heard you say that you didn't want to throw anybody under the bus. Tell me more about that.
Well, like I said, I said that I felt like the anesthesiologist could have told me that the patient wasn't under general anesthetic, but I also could have clarified and asked and been more vocal and for that for myself. So, it's 50-50.
So I'd like to take you back to the prep that you performed, and starting at that point in time, had the patient been prepped prior to you performing a prep?
Yes, I mean, the towels on their face, so I had not seen the sort of nasal cannula and oxygen, and the surgical site was open. That was it. So yeah, it was all ready to go. Yeah.
Over here.
Is there a time during your usual process where the type of anesthesia is usually reviewed prior to beginning your case?
For some cases, but I mean, when I've done these before, these specific procedures, no, because it's just assumed that they're going to be under general anesthetic.
So the difference in consistently communicating that information, the type of anesthesia, is the type of case you're performing.
Specifically when I'm just placing burr holes, I would assume the patient was under general anesthetic.
So, okay, so what I hear you saying is when you are placing a burr hole, usual process is general anesthesia. So you don't necessarily communicate that with the team, but if you were to be conducting some other type of case where you're using conscious sedation, and that's also the assumption, you don't communicate that either. So that's not a normal part of your process.
It's difficult to say. There's not a set procedure in place. It's kind of,
Did you have a question?
I was going to ask, how long have you been using this prep?
A couple of years.
Did you, when the team or you personally made the decision to switch, did you have a rep or any kind of in-service teaching about the prep?
To switch to the
Yeah,
DuraPrep?
when you made a choice to.
We were not trained on DuraPrep, no.
Yeah.
One more.
Go ahead.
What was the? Okay.
Let's go here first, then we'll come back to Mark. Go ahead.
Thank you. I wanted to take you back to the timeout process. Could you share with me, do you usually ask any questions about fire safety and the fire assessment?
No, that's not
or
on the
risk
checklist.
assessment during the timeout process?
No.
And over here.
Okay, one
Marty,
more question.
Last question.
Well, I'm curious about the reaction of the anesthesiologist as this was happening. You mentioned looking at him and shooting him daggers. What was going on with him or her?
It happened, pretty quickly. So I just remember them telling me that, he's sedated through an IV, and it wasn't really time to gauge, emotions or feelings with that. It was just I felt like, okay, we need to wrap this up very quickly.
All right, let's stop there. Let's give Michelle
All
a
right,
big
let's
round
give
of
it up
applause.
to everybody.
And Andrew, a big round of applause.
I think, Bruce, they got about everything they needed to get out of all the different
Yeah, that was
different
really
questions.
interesting. I had never done this one where we had the audience do the question. We kept Andy.
Do
in
I get my
character the whole
medical
time.
degree now?
Andy. That's above your pay grade, Andy. But
Andy has to memorize a lot of medical words and facts for some of these cases, so nice job. Well, what did you guys observe about what went well, of what you might do differently? What did you learn about how to conduct these interviews?
I thought you did an amazing job of every time he started to throw guilt on himself and, it was my responsibility. She did an amazing job of saying, I just want to reiterate that we're not blaming, we're just trying to dig into the facts. I thought that was great.
Amanda in back there.
I thought she did a really effective job of leading when she needed to and not when she shouldn't have. Because leading can potentially alter one's perception of the events. But at the same time, when he would kind of come to a dead end, then she would pull when she needed to pull.
So Amanda, could I give you some feedback about the questions that you asked?
Sure.
So how would you describe the line of questioning that you asked?
I felt like I had to be very careful not to be accusatory.
And do you think that you succeeded at that?
Not always.
Okay, so what was going on there? Though, why were you conscious of being accusatory, and why do you think you didn't succeed at that?
I'm really, really detail-oriented, and maybe I needed to use less you statements or something along those lines.
I don't think it was exactly that. What kind of question did you ask? Do you know what kind of question you asked? They were all closed-ended questions.
Okay.
Did you? Would you? Have you? They all
to reframe them.
They all could have been answered with a yes or no question. And I felt they were pretty pointed. So if you were feeling this accusatory thing, I was feeling that too. Andy's not up here anymore, but I felt like
he's coming up here, Bruce, because he's paying attention to you.
Andy, are you back there? Well, why don't you come up and do you want to reflect on Amanda's questions? Amanda's back over here. Yeah. Did her questioning strike you any differently than anybody else's?
Oh, that's interesting. Half because I'm struggling to recall the medical facts.
Yeah.
Half my brain's there, and half my brain. They were a little bit accusatory, actually. I felt.
Yeah, I was asking them. I'm like, I need to reword
but it's
this.
interesting that you were sensitive to this. You sort of know yourself.
Yeah.
The most direct feedback I can give you is ask open-ended questions. And then there's a deeper thing, which is like about your attitude towards the process, which is an attitude of curiosity, exploration, and even collaboration with the person to uncover the facts, when it was a tiny bit prosecutorial.
Bruce,
you know what I mean?
I would, as I mentioned to you back there, I thought they were great questions, but I felt like I was in a deposition. The way
everyone in my life feels that way.
I'm just saying that's a helpful thing to know. The way I looked at Bruce and I said, "Awesome questions, but boy, this is cross-examination."
Yeah. So like.
So that's your style. It's interesting that you're consciously aware of that. So that's an opportunity for you. If you find yourself in this position, that's probably going to be not the ideal strategy in this situation, because it will feel,
My question then becomes, how do I get that level of detail?
Yeah.
Because when I'm asking an open-ended question, it's hard to get the same level of detail I'm seeking.
You're feeling like only these directed questions will get you the detail that you want. I'm not sure I agree, but I want to let Tim see what do you think?
So really go open-ended. And that's where you would say, okay, take me through another kind of case where you'd be doing this and describe to me what would happen. And then as he goes through it, then he may begin to volunteer. And the more I reflect on what you're saying is, we don't always talk about the anesthetic. And sometimes I'm not even there for the discussion because it's my assistant.
But you can always keep following up. Tell me more about that.
Yep.
Tell me more. Would you say again what happened? So I think there's ways of following up with open-ended questions which don't carry the same kind of implication as the closed-ended questions, especially when they come one after another.
As I'm thinking about it, where in the process is that communicated?
Exactly.
Yep.
How does that normally go? When would you normally talk about it? All these are open-ended. Who, what, where, when, how. These are open-ended. Andy, you were going to reflect on
I was just going to say that at the end there, what we did, I wouldn't beat yourself up about those sort of prosecutorial kind of questions, because everyone is kind of just filtering out questions. And what Michelle did really beautifully up here, I thought, was there's a sort of a meld of open-ended questions, some closed-ended questions, and sort of supportive statements, and they were all kind of in a nice sort of balance, where I thought that you got a lot of detail and specific answers, but it was never we were never far away from you sort of explaining why it was important, or why you respected me, or why it was important. And I think if you had the time that Michelle had, maybe you yourself would have done that.
Yep.
Yes.
Yeah, I agree. I agree with that.
Yes, right across the table.
Kind of along those same lines, I thought one of the things Michelle did really beautifully that I realized partway through is you took Andy back to a how are you doing sort of talking about emotions right kind of in the middle of it.
Yeah.
And then went back to the event piece to say, okay, now let's go back to that. The patient has just moved. Can you now
yeah.
tell me more about that? And I thought that was really pretty brilliant.
I agree.
Yeah, and
Highly
I liked
skillful.
that. Nothing
Yeah,
I
to that
would've thought
end,
about.
Andy, I want to ask you this because when we did the air embolism case, at one particular academic institution, it took 2 hours to get the information that open-ended questions were obtained in 10 minutes. I mean, it was the most painful thing we went through because Andy didn't feel comfortable. Tell me about your comfort level with Michelle. The whole goal, remember the rapport, the trust, all that stuff. Could you share a little bit of that? Because that is the key to getting a really effective cognitive interview done, is that piece of it. Can you share that a little bit?
Yeah, I mean, I think I just went over that a little bit. I thought it executed brilliantly, and I think just because of what I said, that there's a mixture of different types of questions, and you're obviously just a very sort of caring, affable person. You sort of exude that, and so
she's a good actor too.
Yeah, exactly. There you go.
Andy, I wanted to say, you can get out of character now. You can drop the Scottish accent.
Right.
You don't have to keep that up all afternoon.
But no, I thought you did a masterful job there.
Yeah, I would agree.
Yeah, that was a really interesting combination of care for the caregiver in the middle of the cognitive interview, which is the rapport building part. Other questions or comments about how it went and what you learned?
I just have a question on, like, everyone came up with good questions to ask. So do you, before you interview someone, does your huddle come up with all the questions that you want to ask and jot down notes? Or do you?
Absolutely. So that's why I gave you guys that document. And that's why you have labels of the 26cc applicator and the 6cc applicator in there. And if you look very carefully at the label of the 26cc applicator, it makes it very clear, never use on the head and neck. He used 2 of them. So you're going to do your homework before you get in here, and you went there. You didn't go there initially. He kind of volunteered it, and you were great at getting it out. But you want to do a lot of homework before you go in there doing it. And that's why with Amanda, you had already done your homework about, hey, in general, kind of what happens. Can you guys share this with me? And then what you're going to get back is attending neurosurgeons very seldom get down and dirty in the details. In this case, they're busy. He happens to run in there to do that.
I also thought Clay did something really nice at the beginning of his, which is, do you mind if I take notes?
Yep.
And there could be a similar question. If you come in with a pad full of questions, you say, there's a bunch of questions I wanted to get through. Do you mind if I refer to my notes so I can make sure I don't forget any important questions? So I think you can come prepared with a bunch of questions.
There you go, Bruce.
I have a question about logistics. So it's 3 o'clock in the morning and the burr hole fire happens.
Yeah.
Are you calling your huddle in, and are you in-person meeting at 3 a.m.?
So, well, it depends on who's in and around. For the communication with a family, we will do the huddle, and if people are there, they're there. If not, we do it on the phone. Because you got to talk to the family. And that's the most important first huddle. This can wait till the morning when you come in.
Okay.
Yeah, I would not come in and do an interview here. You need to calm down. His focus should be on the patient. All that. He's got to figure out when to do the burr hole. But the huddle will be talking about that. Who's going to interview, who's the best person to interview the neurosurgeon, the nurse in the room, and the anesthesiologist? How are we going to do this tomorrow? Do we have Michelle? Michelle, you in tomorrow? You might be the good person to do that. So you might be deciding that, but you don't do the interview at 3 in the morning.
Back over here. Can I just clarify? Wait till we get you the microphone, please. Thank you. There you go.
Thank you. I just wanted to clarify, Tim, are you saying that you would talk and do the huddle on the phone, or you would have the conversation with the family on the phone immediately?
Oh, never. I would never have the conversation with family on the phone with this. It is to huddle on the phone.
Thank you.
Because your administrator on call, somebody else, they got to go in and talk to them because it's 3 o'clock in the morning. Yes, Carol. Whoa.
Oh, no.
Yeah, chat box.
Someone's going to put an eye out.
And this really goes out to everyone. So the surgeon hasn't done the burr hole surgery yet, but are we sending him back in to do that? I mean, how do you all feel? Because I got to tell you, if I was the family members, I wouldn't want that surgeon going back in because, not that she's done anything wrong, but I'm just thinking, where are they?
Yep.
So how would you all handle that?
Hold that thought, Carol.
Okay.
That is after lunch when we do care for the caregiver. No. What is she bringing up that we talked about? The first workshop, we talked about it. Do you remember what the phrase is? It's called the auto pause. Remember, when is it a pause where this surgeon is not getting back in there, or this anesthesiologist whose first patient died on the OR table doesn't go back in there again? We'll get into that after lunch.
Okay.
It's a really critical question, Carol, that other people have brought up.
All right, back over here to the right.
Yeah.
I have a what-if question.
Okay.
So Michelle had told him that we're getting this information, we need to go talk to the family. What if the surgeon or provider doesn't want them to talk to the family?
Well, so you don't have a choice.
Okay.
As you know, Joint Commission standards, the ISO standards, all that require you to have a process to go in and disclose unexpected events to patients and families. And so what you tell the surgeon is, you know what our practice is, you know what our policy is, you know what we're required to be. We'd love you to be there, but we've got to go out and have this conversation. And we want to love you through it, or however you want to phrase it. Because from my view, the days of them being able to veto the conversation went out in 2002 when the new Joint Commission standard came out and said you must have a process, and they're going to survey on that. Now all the dirty details and the other stuff you share is up, for conversation. They don't have to go. It just depends on your policy to do that. Marty. Really good question, though. Marty.
So, Tim, on the 3 a.m. in the morning scenario where you said, you can wait for the cognitive interviewing piece maybe until the morning and you huddle and get the right questions, what about the piece that Clay did, the care for the caregiver piece? Is it okay to let Andy wait until the morning to have that first conversation with him, or does that need to happen faster?
It's case by case, Marty. It's really, really, really going to depend. A lot of people wait. I know Heather Farley, who you saw in the video, would say it's okay to wait because Clay picked up on it. Wow, you look shocked. Yeah. We're here for you. We're ready to be able to do that. So it may be the administrator on call who just goes in, talks to them, how are you doing, how's the patient doing, and their job is to look and see how traumatized are they. And if they need triage then, they need triage then, but in general you can wait. Really good question. That's why that immediate response, that crisis management is so important, and that you do have somebody in-house, whether an administrator on call or somebody else on call, who's going to come in and just assess the team in the situation. Really good question. All right, so let's jump into more facts. Let's give it up again for Andy and Michelle and all that sort of stuff. That was great. So if I could get the slides back. So, and again, this is a real case. So what happened? We know we had nasal cannula because the patient had severe aortic stenosis, would not have tolerated general anesthesia, and had the nasal cannula. What else was there? What else was there was the DuraPrep. And what you heard from our surgeon was 2 26 cc applicators were used, which is 52 cc's of alcohol-based prep solution was used in this very small area. And then you had the electrocautery that is there. So putting all this together, somebody took my sterno. We basically had sterno in the OR. Okay? And in fact, when we did the initial investigation here, I have a picture of it. I didn't pull it in here. One of the things that we did is we pulled back the sheets on the OR table, and the foam mattress the patient was on was completely soaked still with DuraPrep. Because again, this is 52 cc's. So it didn't matter how long you waited, although that was really good questioning, how long did you wait? There was no way it was going to dry, okay, at that time. So the other piece that's important is that Marty, where's Marty? You were part of this, right? You were part of organizing it. Yeah. So the WHO Safe Surgery Checklist in 2009 did not include fire assessment. It didn't include it, which many people believe, and this is right when DuraPrep was really ramping up, ChloroPrep was as well, the alkali-based prep solution. So it's fascinating to see this very thorough checklist. There's nothing in here about fire assessment. And other information that is really important to have learned related to this. So here is the label from the DuraPrep, the 26 cc applicator. Okay? And when you flip it on its side, you can see do not use for head and neck surgery. We use 2 of them. Anybody in this room worried about liability? Yeah, that's a big deal, right? Very clearly. But what else does it tell you about human factors? Labels and warnings don't work as a strong prevention for harm. All right, now you look at the 6 cc applicator. You can see here it says, patient pre-op skin preparation for head, neck, and small prep areas. This is the one that should be used. Andy, or Dr. Phillips, are you still here? Oh, he must have stepped out. I would ask him as well, were these available to you in the operating room when this happened? And his answer would be no. We had none of these in our hospital. I did this talk about 7 years ago to a bunch of C-suite people. Everybody started pulling their phones out and texting. And many of them, with horror on their face, realized, even though they do head and neck surgery, none of them had the 6 cc applicator. This is the, where's Carol? Is Carol in here? All right. I can tell this story then, because she's a rep. The rep for DuraPrep did not want to sell us 6 cc applicators because they make way less commission on the 6 cc applicators, so we never had them. That's why there was never an in-service, because then people would have realized the fact that we didn't even have the right applicator in the operating room at the time. Think about this is the critical stuff. So you need to think about, for the nurses in the room, the neurosurgeon, and the rest of it, let's just quickly run through this, because boy, people were really upset and sad about a fire in the operating room. But let's just think about the neurosurgeon. Actions as intended, no. Andy didn't intend a fire. No evidence of illness or substance use. Did he knowingly violate a safe procedure? No, he was doing what he usually does. Could someone else have done the same thing? Abso-freaking-lutely. Had it happened to him before? No. I can tell you at this time at Cleveland Clinic, they had 6 fires in 6 months when this stuff initially came out. How many of you are familiar with what happened in Nebraska when this started happening? The fire marshal banned the use of DuraPrep in operating rooms. They had so many fires. I mean, this was one of those really big, important things to begin to think about related to what some of the problems, what some of the other issues are. You know what I mean, related to this piece of it. So you have, so let's run through again. Remember, this is, we're now sort of back to the summary of what happened. What are all those issues that you now need to think about as you pull this together of how you're going to change things? So just throw out some things that you've now learned that hopefully you've written down are things you're really going to need to fix. What's that?
Product availability.
Product availability, and go further up the chain. Actually, here, let him pass it off so everybody hears it. So it's product availability. Let's go even further than that.
Yeah, I think beyond availability is there a standard product or a standard procedure for each case? A product per case or standard work for each procedure.
There's that piece. Tell me, let's go a little bit further on the product question.
Do we have the right product? And
do you have the right product? And go even further up that.
Do we have a value analysis committee?
Yes. Why? Why is it that this ended up that way? So we got to go way up the chain, which is when we start going to new stuff like this, who's doing the risk assessment? This is an enterprise risk question. Which is so great for CNOs and CMOs and others to get into. You got to go way up the chain. It's, oh my gosh, we're getting all these quality metrics out there, because why were we using DuraPrep? We talked about it earlier, to prevent surgical site infections. So somebody thinks, oh, good idea to use this. It's now a best practice. But you got to go way up the food chain to ask all those questions. What else related to this? Over here, and then we'll go over there.
It would be, is there standardized training on what is appropriate in the action? Like, he didn't have any official training for
using the DuraPrep. What else would it have been very official to know about, which was above his pay grade? So go ahead, say that again.
Not under general anesthesia.
Right. What do you do differently?
Right.
In other words, what is the practice
flowing,
if they're not under general anesthesia? So what are some potential practices to think about in this case that could have been done, that should have been done?
Well, not using that prep, or
that could be one, but you want to prevent the infection.
Or
what else did you not have to use?
The oxygen. Right.
You know, we in anesthesia, it's just like standard routine. Put a nasal cannula on, crank that baby up, and go back to reading the Wall Street Journal, you know? And I'm an anesthesiologist, so I can say that. But no, really, it's to put it on, oh my gosh, because in many ways, using oxygen in a case like this is not a good idea, because you want to know if breathing room air, he's starting to deteriorate. So the biggest thing is, whoa, do you really need this oxygen? You know, or better yet, any of you, again, involved in the OR ever, how do plastic surgeons manage this when they're working on the face, and it is a patient who really needs oxygen? How do they manage it? Literally, how would they manage it? How would they deal with it? What they say is, they will say oxygen off and wait before they use the mini cautery on the face. They're so aware of that. There's such great communication. When I used to do anesthesia for our oculoplasty, they say oxygen off and then oxygen on. There's this huge amount of communication that goes, so you're removing to the extent you can one of the fire triangles. Okay?
So Tim, on the safe surgery checklist, when that was developed, that was driven by Atul Gawande, and he had this consultative process with every surgery group that he could think of. Why didn't the surgeons bring that up yet? Was it just the
because they weren't.
timing?
I will tell you in part, I think they needed more anesthesiologists involved in that group.
Okay.
Because we're the ones that were the people originally dealt with fire because of our flammable anesthetics.
Yeah.
And because when he was building that, it was using a lot of the alcohol-based prep solution. I think if they brought anesthesiologists in, they would have got it.
Okay.
More of them into that process. It's a matter of having the right stakeholders there.
Yeah.
And that gets back to, we in anesthesia own one of the parts of the fire triangle, the oxygen piece. And I think that Bruce.
Is it realistic for a surgeon to debate the anesthesia, to discuss the anesthesia right as the case is starting? Would that happen in prep for the case? Or I'm just wondering, would that conversation really happen in the OR? Let's not use the oxygen?
Well, actually, it would have happened probably before the OR. And what normally would occur is, this is a patient who is very sick. And there should have been a conversation between anesthesiologist and surgeon saying, hey, I do not want to give general anesthesia. I'm just giving you the heads up there. I just think it's too risky, to do that. And that would normally happen, where there'd be a collegial conversation to say, we're going to do this different than I've ever done a burr hole with you. And that is just the normal piece. It's somebody said either a briefing. Who used the word briefing? Which I thought was somebody in here this morning said briefing. You would do a brief. It's not the timeout. It's a briefing. Say, hey, we're doing Mr. Thompson now or Mr. Stevens now. You guys know he's a really sick guy. His heart is really bad. We don't even know if the family is going to want to go ahead with a valve replacement. But because he's so sick, we need to be prepared for all this stuff. And I just want to let you know, we're going to be giving sedation. We normally don't do that. And so that's that conversation would normally happen, Bruce.
I mean, as a layperson, it's a little shocking that the surgeon doesn't sort of know what kind of anesthesia. I guess my fantasy is that there's a long discussion and big planning process before the surgery starts about all of it.
And that's not to say it didn't happen here, Bruce, but a lot of what happens is it's the junior surgeon who's with them, who's having this conversation. And remember, this person's running from room to room. And so sometimes there's, as Andy said it perfectly, there's assumptions that are made that somebody has had that conversation. Yeah. Other issues.
My question is, after this case, did you change your process on products? So we changed. I have a loud enough voice.
Here, try this one. We need a recording. Thank you.
Oh, okay. If you're changing your products or the things that you're doing in the OR, and I'm sure we all do this on cost base, everybody's changing things up all the time. Because of this, do you make sure that there's training for the surgery staff, whether it's just the surgery manager that passes that on when you have new products?
It's training. The other part I was going to get to is that we did start to practice a lot, is we would practice simulated fires in the OR. Because if we're going to have to deal with alcohol-based prep solution, this could happen. We want to make sure people respond immediately and know the right thing to do. That's where it really changed the culture of the organization, because everybody was talking about it. I will share another thing with you that it was very tragic that happened that related to product replacement. What kind of trachs do you guys use in your organization? Trach tubes. What kind of trach tubes do you guys use? Shiley, Portex? So there's two big manufacturers, Shiley and Portex. Those trach tubes come numbered. Bigger the number, the bigger the size. but the numbers in Portex do not match the numbers in Shiley. We moved from Shiley to Portex trachs. 2 patients passed away because we put too short of a trach tube in. And so that was another thing that raised this awareness. It was all happening around the same time. Oh my gosh, we need a better way when we change product to do an enterprise risk assessment when we go about doing this. The other part is, as we lead towards lunch, is the lack of community, lack of training, the lack of in-servicing. The other pieces, again, that are related to this piece, the opportunity to improve a checklist. Somebody, I think, Dar, you or Rhonda mentioned, making sure that on the case carts for head and neck cases, you would never put a 26 cc applicator. You get the 6 cc's, there'd be one put on there, so there's got to be a whole way to think about the redesign of how you make this stuff happen. So that was one of the other opportunities that we see there. Any other comments, questions, or suggestions as we get ready to go into lunch? So you can imagine now the conversation with the family. There's some very interesting liability issues here. Care for the caregiver. You started it off. That was awesome, doing that part. Any other questions related to learning from the event, what it is that happened that we should get out before we head to lunch? Yes?
When did they do the burr hole?
So the burr hole literally happened within 12 hours.
Okay.
The plastic surgeon came in, did the assessment, realized this is going to require a lot of care, but I don't need to do anything super acutely right now that should interfere with you. We need to get the burr hole done, talk to the family, because what was one of the options the family could take? What Bruce just said, go elsewhere. I mean, you need to give them that option. You now need to redo the informed consent. So obviously the family's shocked. You need to learn as much. This is why the urgency of getting these interviews done is critical. So you can now share with the family, have an informed consent. That's what happened in this case, and as well as other things, but did have the burr hole then removed.
And did they do it at your facility?
Yes. Stay at the facility. We'll talk more about one of the other things that we use. Marty mentioned it at the last workshop. We'll get into it after we do the care for the caregiver enactment, but that's part of it. Yeah.
On the event review, the next question I would ask is, has this happened anywhere else? So we're dealing in this hospital, but maybe this same thing has happened someplace else, and because of all the things that interfere with the transparency, like liability or shame or reputation.
So this got shared in some of the biggest conferences as we could immediately, so people would know, because we then learned it was happening hundreds of times around the country with this new use of the DuraPrep. Like I said, 6 times in 6 months at Cleveland Clinic. In Nebraska, the fire marshal banned it. So there was a huge task force that was put together, Marty, that you will see when you see the solutions of AORN, just to share it with you. They totally redid the checklist because that this came out. There was a big call to arms saying, oh my gosh, and then Bruce and I are going to get into a conversation of, and you can just think about it, we'll ask it in more detail, the unintended consequences when we make very thoughtful decisions to improve quality. You have these unintended consequences. And I want you to think about it, because we have a whole list, Bruce and I have, of we did things that we thought were really going to improve things, and there's this huge unintended consequence. This is an example. We're really trying to prevent surgical site infections. We didn't think about the notion of how PrEP solutions are used, all the rest of that sort of stuff. So there were a lot of people harmed when this piece happened. And it still happens around for doing that part. Any other comments or questions before? So what's our plan for lunch, and how long do you want us to go for? Half hour, 45 minutes? 45 minutes?
We have an hour scheduled, but I don't know if we try to go for 45. Is everybody okay with that?
Yeah.
Let's go for 45. So it's noon right now, so if we could all kind of be back and ready to go at 12:45. There is a buffet line that's set out here, and then for those of you who don't know, there are restrooms on this floor, but also on the 2nd and 3rd floor, because it can get kind of crowded in there for the ladies. So,
alrighty.
Anything else or questions anybody has before we take a lunch break?
Awesome. Okay, thanks everybody. See you after lunch.